Okay. Good morning, everyone, and I'd like to welcome you to our 2021 season for the Grand Rounds, brought to you live here from our Learning Center at 28th in Chicago. We have a great speaker this morning who will be introduced shortly by Dr. Saraja, and I just wanted to welcome everyone. I want to acknowledge the work of Dr. David Hurl, who chairs the Education Committee, and the really broad spectrum of our group that participates in that committee in selecting the topics and the speakers for the Grand Rounds. We've had great participation. I'd also like to thank my friends at Janssen Pharmaceuticals, Chuck Stark, and Denise Burt and Chelsea Wicksberg for graciously sponsoring this morning's Grand Rounds despite the inconvenience of being remote. They've been really strong supporters, as you all know, of our Grand Rounds throughout the past several years. And so thanks to each one of you and to your company for this. This morning, we have Dr. Maurice Sarano. He's been with us now for over a year doing his research work. And I'm going to call Paul Saraja up to introduce Dr. Sarano.
Thank you very much, Scott, and good morning to all of you. We do have a couple of featured studies that we want to talk about and introduce before we get on with Grand Rounds. The first study is the Repair MR study. This is a study that is starting here very soon. Many of you know that MitraClip is currently approved for high risk or prohibitive risk patients. And in this study, we'll be randomizing patients to MitraClip versus mitral valve surgery for those who are intermediate risk. And it's very, very exciting to see this start. And I think we're starting this week. Is that right, Jane? Yeah. Do you want to move on? Do you have that, John, or do you have? And then the other study is the High Life study. So this is a study, as many of you are aware, the TMVR field has really been focused on transapical devices, and we're moving more towards transfemoral transeptal approaches. So the High Life is a technology that is a transeptal TMVR. And this technology will be in an early feasibility study, and it's for patients with prohibitive risk MR that's symptomatic. And we'll be enrolling these patients with a site initiation visit this week, right, Jane? Oh, that's right. Yeah, so to show you a little bit about what that study is or what the technology is, maybe you can switch over. Do I press here? So this is the technology here. Oh, sorry. So it's a transeptal transfemoral technology, and this company is called High Life. And again, it's an early feasibility study. It's a 28 millimeter prosthesis. And the idea is to have a low profile device that reduces the risk of LVT obstruction. And the way this is done is that it's placed through the right femoral vein. And the first thing that's done is a loop is created around the mitral valve apparatus to help cinch the anterior leaflet. So it's a way of capturing the anterior leaflet to reduce its excursion into the LVOT. And so you'll see here, this is how it's done. So I'm just going to speed it up in the interest of time. Oh. Sorry, Maurice, I'm not sure how to open your computer, but it's okay. Hopefully technology is a little bit easier, but once that loop is created, you'll see here, so that loop is created, then it's exchanged for essentially a subvalvular anchor. And then when that subvalvular anchor is in place, there's a transfemoral device that then comes up and goes around. And so this is just that anchor being placed retroaortic. That. And then here comes the device. Put this play here. And the valve is put in like that. And so it's very exciting to get started here. And we're looking for patients for either Repair MR or for High Life. If you have patients, please call Jane or other members of our research staff, or call me. And certainly we'll be very interested to see how these technologies turn out. So without further ado, it's really my pleasure to introduce our keynote speaker this morning, Dr. Maurice Sarano. Dr. Sarano is well known. He is originally from Tunisia, right? Born there, educated in Paris, got his MD at Paris University, where he became a young professor, and then came to Mayo Clinic in 1991, and quickly really established an international reputation in the field of valvular heart disease, especially valvular regurgitation. He has published hundreds of papers and really become renowned in this area, and has really led the way, especially for quantitating valvular regurgitation. He has shown that it may sound simple now, but simply quantitating and measuring valvular regurgitation is prognostic. And he's really pushed the envelope in terms of getting us to get patients treated sooner with surgery. And with that, if you think about what he has done, he really has led the way to improving the lives of thousands of people worldwide by advocating for such therapy. We've had the pleasure of having his mentorship here. He's been a mentor to many people for many, many years, including myself. And he joined us about a year ago as a senior scientist in the foundation, continuing his invaluable mentorship to me and others in our Valve Science Center. Today he's going to be speaking about his specialty, mitral regurgitation, and we welcome Maurice. Maurice?
Thank you. Thank you. Thank you, Paul. It's really been a strange year with the pandemic and not exactly working the way we wanted for, but you know, it's better than being in the intensive care. So we are not going to complain, but we have to adapt to the situation. And I want to thank Paul and thank Scott for the incredible way they welcome me and my, how can I say, idiosyncrasies. And so it is really a pleasure to be here and to be part of this incredible team that Paul has constructed, Joao, Mario, and an incredible, very large and beautiful team. And this is not Minnesota. Huh? This is a picture when I was on the beach in Israel, and so we hope that the warming. Oh, the mask, yes. I don't need the mask, and we're far away. And so we're hoping that the warming of the climate will get us to something close to that, maybe. So today, Scott asked me to talk about functional MR, and functional MR is shown here. It is, mitral regurgitation is the most frequent valve disease in the population. Whether you look at the entire US population, whether you look at the community, it's the most frequent. And here you see a case of functional MR. The guy is not doing so well, huh? Blood pressure 70. And you see that the leaflets are fundamentally normal with a little bit of calcification. So you can accept that it's functional MR with a little bit of calcification, but the leaflets are structurally normal and there is mitral regurgitation, and that defines functional. I've put secondary in the title because that's the word that is used in the guidelines, but I hate this word and I will not submit to this word because all regurgitation are secondary to something. So I'm very confused when people say secondary, you're organic or you're functional, you understand what it means. Secondary, I don't understand what it means, but we will continue to use functional, and I think that sometimes senses come back to people. So here is a paper that we published last year with a young fellow. She's from Belarus, so the family is currently in the little turmoil, but she worked in France and came, and then they're back in France. And so we looked at the cause and mechanism of isolated mitral regurgitation in the community. And when I say in the community, you have to understand what that means. Community is, we talk about it when we can measure things in a limited geographical area, defined geographical area, and Olmsted County is very particular in the word for that because it's a limited geographical area where the care is contained and it is isolated enough from the rest of the world that we can look at the outcomes and what happens next. As you know, in a big city like Minneapolis and St. Paul, the patients may go here and there and come, and so you never know really the outcome of every single patient. In a contained area like Olmsted County, you can talk about the community, and we've shown that what happens nationally by the systematic screening that the NIH has done is very parallel and very similar to what happens in the community. So we know that it's a valid model. And so what do we see about mitral regurgitation in the community? We define FMR as structurally normal valve plus mitral regurgitation, moderate or severe. And it can be due to two mechanisms: atrial enlargement causing functional MR, and we'll see one example, and left ventricular remodeling causing functional MR. Overall, functional MR is 65% of all mitral regurgitation. So the vast majority of MR is functional. And you have the distribution of those two causes, 38% for LV remodeling, 27% for atrial enlargement. So grossly, 1/3 is organic, 1/3 is functional MR due to LV remodeling, and 1/3 is atrial enlargement. And I'm going to talk about the atrial enlargement, atrial remodeling MR. Here is the survival curve in the community, expected survival, and you're going to see a number of those curves, and observed survival. And the difference is the excess mortality. The hazard ratio as compared to the general population is 1.67. So there is an excess mortality. So you want to remember those terms: expected, observed, and the difference between the two is the excess mortality observed in these patients. And here is an example where you see the left atrium massively enlarged, and the annulus is enlarged. The leaflets are normal, so they open and close apparently normally, and you see the regurgitation here due to the massive annular enlargement. What is interesting is that normally the pepper muscle that you see here are giving cords to both the anterior and posterior. Each pepper muscle is giving cords to the anterior and posterior leaflet, and they're keeping the leaflets together, which is not the case on the tricuspid side. So but there is a limit of annular enlargement whereby the pepper muscle cannot keep the leaflets together, and there is annular enlargement. And we can see that there is MR. You can quantify this MR. You see that there are two jets. And despite the fact that there are two jets, you can quantify one and the other. And it's very easy to do. There is very often tricuspid regurgitation associated. And look at the shape of the MR signal. I'm going to show you another shape of the MR signal, and you'll understand what is the difference. So this is an example of the atrial form of functional MR. It is quite frequent. And what are the characteristics? These are the oldest patient, on average 80 years old. Mostly women. That's the only group where it's mostly women, very often symptomatic, very often with a history of atrial fibrillation that has caused the atrial enlargement, and with a large load of comorbidity. This is the Charlson Index. And if we look at what determines that MR in this paper by Gertz of a few years ago, it is the annular dimension that trumps the LA volume index, but the basic cause is the atrial enlargement that caused the annular enlargement that caused the mitral regurgitation. And if we look at the distribution of age, distribution by range of age of the functional MR, the green one, the functional atrial, you see that it's a disease of the elderly, and often the very elderly patients, progressively increasing over time. And the echo is interesting because there are many questions. On average, the regurgitant volume is 37 cc's per beat, which is not enormous, but it's the same regurgitant volume as the FMR due to LV remodeling. Regurgitant orifice 0.2 centimeters square. EF is in contrast to the LV remodeling normal, and the LV size is normal. So putting a valve, percutaneously or not, in that small ventricle will not be that easy. You have to make sure that you don't get the obstruction of the LVOT, and it's an issue here. And the systolic blood pressure is elevated in those patients. Outcome-wise, we've seen the excess mortality, and here you see the excess rate of heart failure occurring over time. You see they have a much smaller regurgitant volume than organic MR, but they have more heart failure than organic MR. So there are a number of mysteries. How come with a lower regurgitant volume, they have more heart failure than organic MR is a question that is currently unresolved. What is clear is that these patients with atrial form of functional MR are almost never operated. Overall, repair replacement in 3% of them, and even in the severe MR, 5%. So 95% of these people, even with severe MR, are never, during their lifetime, operated for the mitral regurgitation, and they remain untreated. So to summarize quickly, FMR due to atrial dilatation, an entity almost completely ignored despite representing 1/3 of all MR, affecting mostly elderly women, often with atrial fibrillation, peculiar hemodynamics, low regurgitant volume, normal LV, pulmonary hypertension, very frequent heart failure preceding excess mortality, almost never mitral surgery, and we are not sure about the role of the MR. Is it the MR that is causing that? Is there something else? Is it FPAF? So we have to look at what has not been done is the gradient of the degree of MR. You take somebody with 20 cc's of regurgitant volume, somebody with 50. What is the difference in outcome of these patients? And we can make a judgment on what can be done really. What is the role of MR in those patients? So we're going to go to the next one, which is the LV remodeling. Functional MR due to LV remodeling. You see the expected mortality again in the community, and you see the excess mortality with the observed mortality here and the hazard ratio, the risk ratio of 3.5 in those patients. So a very serious condition. Here is an example of what we call the type 3B restriction in systole. You see here the restriction of the valve in systole that cannot coapt. The coaptation is reduced. There is mitral regurgitation. So the big thing is the functional MR due to left ventricular remodeling is a ventricular disease. So the issue is what is the chicken, what is the egg? And how does the egg give rise to another chicken and influence the outcome of these patients? So conundrum number one, it's full of conundrums here. How does the FMR happen? Normal leaflet, how does it happen? This is a normal valve, and you see that there is, that's the mitral annulus, and above that mitral annulus, you have a little bit of tenting of the valve. They are kept by the chordae, and the pepper muscle in systole will come closer to the annulus and hold the valve when they come back closer to the annulus. And in functional MR, the papillary muscle is moved posteriorly and apically and creates a tension on the mitral valve. And because the valve do not go up normally due to that tenting, this is the systolic restriction, you have mitral regurgitation. So there is global alveolar remodeling. There is local alveolar remodeling with repositioning of the valve. And there is also annular dysfunction. Here's an example where the leaflet would not touch. It's functional MR. The leaflets are normal structurally, but you see that in systole, the leaflets do not touch. It's an extreme form of functional MR due to LV remodeling in a patient who had an inferior MR. So that's the graphic representation of you're pulling on the side of the mitral valve and you're trying to close the mitral and you can't close it, and that's this traction on the side by each papillary muscle. That's the papillary muscle, that's the cords, and that's how you get functional MR. Now there is an annular component, and you know that with 3D echo we can measure the annulus, and that's what we've done in part. And if you compare the normal annulus to the functional MR, mostly ischemic in this case, you see that the normal mitral annulus is dynamic, contracting in early systole before the ventricle contracts to approximate before the whole ventricle and the pressure rises to approximate the leaflet and do a pre-closing. Otherwise, we would all have early systolic MR. That dynamic of the annulus prevents the early systolic MR. And in the functional MR, the dilatation is mostly anteroposterior, no intercommissural dilatation, and the annulus becomes adynamic. It doesn't contract anymore. And if we see from the side, you see that in the normal annulus, there is an early systolic saddle shape accentuation that keeps the leaflet closer, and you don't have that in the functional MR annulus. So there is a component of the annulus function that plays into the functional MR mechanism. So here, functional MR is a ventricular disease, but how can it be that a functional MR that is of low volume is significant, and how do we grade that MR, and how do we understand and talk to each other? So here is a PISA measurement on a patient with a functional MR, and you see that we can see the flow convergence, and we can discuss of the technical limitation that it has. People have said, oh, it's the orifice is not round, and they need their head examined because it's very applicable, because the orifice is small and far from the top of the flow convergence. So the issues, the mathematical, geometrical issues are not very important, but we'll see that. And here we have a very nice flow convergence radius that we can measure, peak velocity. And I'm asking you to pay attention to the shape of the TVI of the regurgitation. You see, it's very different from what we saw in the atrial form. It's peaking early and it's cut a little bit. And you see that the peak velocity is reduced. And really, this is a sign that there is a big V wave. And that big V wave in the left atrium equalizes the pressure. And we'll talk about that later. But we calculate an ERO of 0.34 centimeters squared, the effective regurgitant orifice, and a regurgitant volume of 46 milliliter per beat. And how much is that? How should we grade it? What name do we give it? Because we have numbers, and to use them in practice, we have to add a word that qualifies that number so we can communicate. And it serves only for communication purposes, but it's a very important step, the communication purpose. And FMR is very strange, because this is a paper published on the SAVE study by Lamas years ago. And you know that in the SAFE study, because they were looking at the ventricular enlargement, they excluded at the beginning patients with MR. So there was not supposed to be anybody with any significant MR. But when they brought the patient to the cath lab, a few had MR, at most mild to moderate, mostly mild. But these people with the MR, they had considerable mortality as compared to the patients without MR. So low volume, low grading, but considerable impact on outcome. And this was troubling because how do we reconcile that? So after that study, we published this paper with Francesco Grigioni, who was my research fellow and has become a great friend from that time. He's now in chief of cardiology in Rome. And this is probably one of the most cited paper I ever had. It's thousands of citation. It was an interesting experience. And what did we see? People with Q-wave MI collected more than 16 days after the MI. And what do we see? We see that there is a clear link between the degree of MR quantified by the ERO and the outcome and the mortality. You see that there is a very nice, with the increasing ERO, you have increasing mortality, which is highly suggestive of causality. Does not finish to establish the causality, but is highly suggestive of causality. But you see mostly that the group with the highest mortality is ERO above 20 millimeters square, 0.2 centimeters square. And you know that in the organic MR, the threshold for severe MR is 0.4 centimeters square. So it raised the question of different thresholds for saying severe based on outcome data between the ischemic or functional MR and the organic MR. And we see the same thing in patients who are asymptomatic at time 0, and we look at the occurrence of heart failure. The MR is very strongly related to the heart failure rate in those patients. Now, we published these papers in the early 2000s, but colleagues in the same institution, you see that the names are from Mayo, they decided to check on their own. People were in the heart failure clinic and were coming and had the report of echo with the MR, and they said, no way. We don't see any effect of the MR. Whichever way we grade it, we don't see the effect of the MR on the survival. So clearly within the same institution, discordant data. Is it whether it depends on the fact that I did the echo or not, or whether FMR is a surrogate for something else? That's the real question. And also, you know, there were many criticisms of what is how valid are the methods and whether the orifice is circular or not, and that affects the result. So many papers criticizing the methods that we use for the quantification and saying, that doesn't work. Small studies being quite critical, but you know, it's critical. You have to examine that and how that works. But we were confirmed by this study in Europe, done in Belgium, showing that the people with more than 20 of regurgitant orifice had higher mortality. But again, the threshold of 20 was just because it was the distribution of patients. We had very few patients, and you see that there are few patients because one death is causing a big decline. So very small study, but going in the same direction. And then the larger study done in Italy with my friend Andrea Rossi, and I was part of that. It was part quantitative, part using the vena contracta, saying, okay, if we grade the MR is affecting the outcome. But still, you don't know because there are not enough data whether it is a surrogate, the MR, for something else. So do we have more studies? And these are two recent papers from the same group So you see the names of the author, it's the same, Vienna, Bartko, and Goliash and their team in Vienna. And they published a letter in 2018 in JACC, and then a paper in 2019 in JACC. And what I'm going to show you is to demonstrate how much you should pay attention when you publish something, because you have to be careful. So this is the letter of 2019, where in that letter, they compare the criteria by ACCHA to the criteria by ESC. And they say, when you measure in blue here, an ERO above 20, this is the survival curve, and it is not well separated from the ERO lower than 20. And the star indicates the curve that we're looking at 5 years here. And survival is approximately 55% at 5 years. Now, a year later, they publish this. From the same center, same authors. And at that time, this is the survival of these two curves. This is above 20 to 30, and more than 30. And here, the survival at 5 years is 40%. How come the same center, the same quantitative data, the same inclusion criteria have a 15% difference in survival at 5 years? I don't understand. I can't reconcile. The numbers don't make sense. If you look at the numbers, here there are 32, in the other paper there are 39. I can't fathom. So these new studies do not resolve my problem because they are discordance within the same center that I cannot explain and not reconcile. So they should have paid a little bit more attention to what they were publishing. And then they did the spline curve, and I'm going to show you a number of spline curves. And the spline curves relates the mortality to a continuous variable. So this is the central line of the relationship, and these are the 95% confidence interval. And you see two things that are troubling me. One is that the curve flattens when you increase the ERO, as if the risk does not increase that much when you go from 10 to 20 to 32. So that's one thing which is surprising. And then you look at the 95 confidence interval, and the 95% confidence interval is very close to 1. So if the 95% confidence interval goes beyond 1, it means you're insignificant. So and it is very wide, showing that they don't have much power to determine the outcome based on these patients. So when we look at the most recent data, it is not convincing. We're still in a situation where we don't know whether the MR is independently predictive of outcome, independently linked to outcome, or if it is a surrogate for something else. The other part which is discordant, so we've seen that the data is discordant, is the interactions. So interactions, this is the paper from Goliash, and that paper was not quantitative, and they were saying, yes, the MR, increasing degree, is predictive in patients with heart failure. And here, what they tell us is, yes, the MR counts, but only in specific subset with an interaction with the symptoms, only in class 3, with an interaction with the EF, only in the EF is moderately down, and with an interaction with the BNP only in the people who have the second quartile of BNP. So, okay, this is some interaction. And then you go to the paper by Bartko, the same center, quantitative data, and they look at interaction. They do not find the interaction that they have previously published with the EF, with the BNP, with the symptoms, but they find an interaction here with the regurgitant fraction. The intermediate range, this is there is an interaction or orifice area regurgitant fraction. So an inconsistency which is difficult to explain. But the most interesting interaction is the interaction that we've seen with the end diastolic volume. So Paul Grayburn is a good friend, published this paper, and it's a theoretical calculation, and that theoretical calculation look at the EROA versus the end diastolic volume here for a defined ejection fraction of 30% and regurgitant fraction of 50%. And what the message is, oh, the effective regurgitant orifice marking severity should be changing with the end diastolic volume. And you say, oh, this is really weird. The regurgitant orifice caused the volume overload, caused the ventricular enlargement, and the ventricular enlargement caused more ERO. But what is that strange calculation? And what did Paul forget? Paul forget that the regurgitant fraction, what's causing the regurgitant fraction is calculated. It's a ratio of the regurgitant volume over the total left ventricular stroke volume. And the total left ventricular stroke volume is the regurgitant volume plus the forward stroke volume. And we calculate the regurgitant volume as ERO multiplied by regurgitant TVI. It's what I showed you before, that tracing of the continuous wave Doppler. The regurgitant TVI is high when the left atrium is compliant, but is low when the LA is not compliant. As I shown you on that first patient with functional MR, you lose the regurgitation quite fast because there is equalization of pressure with a V wave in those patients. So low with non-compliant LA. So let me do the calculation. If somebody has a forward stroke volume of 50 ml, you need a forward stroke volume to be alive. So we can estimate people with very low stroke volume, and we're going to see that again. But if you have a very stroke volume, you're dead. So 50 for somebody 2 meters square of body surface area is 25 milliliter per meter square. Very low already. So very low. So the minimum stroke volume that we can look at, 50 of forward stroke volume, and the patient has an ERO of 0.3. With an LA compliant, the regurgitant TVI is 150 centimeters. It makes a regurgitant volume of 45 cc's and a regurgitant fraction of 47%. So the regurgitant fraction is the consequence of the hemodynamic equilibrium, not a primary mover. So you can't calculate with a fixed regurgitant fraction. And if the LA is non-compliant, the regurgitant TVI will only be 100, and the regurgitant volume will only be 30 cc's because the driving force of the regurgitation is reduced, and now the regurgitant fraction will calculate 38%. So we have not changed the forward stroke volume, we have not changed the lesion severity, but depending on the driving force, which is dependent on the compliance of the left atrium, you will have a very different regurgitant fraction. So this calculation is all wrong. All wrong. The concept that you could have severe MR with a regurgitant orifice of 0.1 here, or that you could have moderate MR with a regurgitant orifice of 0.4 is completely out of whack with anything we know in reality. And so Paul published a second paper after the discordance of COAPT and MITRA-FR, where he looked at the ventricular volumes and the EROA and said, oh, this is proportionate, this is disproportionate mitral regurgitation because the ventricular volumes here are much smaller for a bigger regurgitation. You say, so the blood is incompressible. It has to come from somewhere. So let's look at the data in the COAPT trial. So the COAPT trial is here, the device and the control group. And if you have the ventricular volumes here, the absolute ventricular volume, and on average would be 192 ml for end diastolic and 135 for end systolic volume. So it makes a total stroke volume of 57 ml, but somebody who has an EROA of 0.4 has a regurgitant volume of 60 cc's. So what is the conclusion of that? So if you conclude that is, congratulations, all the patients in COAPT were dead before being intervened on because they had no forward stroke volume. Or the more logical explanation is that because these patients were alive, so they could not have no forward stroke volume, COAPT echo measure of LV volume was severely underestimated. And if you say, okay, these people have a 50 cc's of forward stroke volume, 50 cc's, 50 to 60 cc's of regurgitant volume, so it makes 100, 110 of total stroke volume, ejection fraction 31%, approximately end diastolic volume 300, 310. The point should not be here, but here. And in fact, that's what I said to Neil Wassman, was the core lab of the COAPT trial, that the volumes were not compatible, that they were underestimated. He said, oh, absolutely, yes. The echoes were not of good quality, so we draw what we could draw. So, oh, everybody understands that the concept of disproportionate MR is impossible. We should not use it. And the volumes in COAPT are underestimated. So that interaction, FMR with end diastolic volume, please forget about it. Please, please, if you want my health to be maintained, don't tell me about disproportionate MR. The blood is incompressible. It has to come from somewhere, and that somewhere is the left ventricle, okay? So now, but legitimate question remain about interaction between FMR and the outcome and other measure. What do we learn about surgical data? Surgical data, here is the first surgical result on mitral valve annuloplasty. It was an observational sort of comparison. And you see that in that observational coming from Steve Bowling Hospital and Center, and there was absolutely no difference in survival in the patient who actually had surgery and the people who would have been candidate for surgery. So no difference in survival overall or even in the non-ischemic subset. So observational, no difference. Now, clinical trials, there were a few clinical trials on functional MR. This trial was done in London by my friend Gilles Dreyfus, and they analyzed people who were referred for CABG, for coronary disease, and some had MR, and they randomized the patient who had MR and an EF above 30% and were symptomatic but not class 4. So here are the characteristics and the usual not very young patients. And the MR is exactly what we observed, 0.2 and 30 cc's of regurgitant volume. And when they looked at the results were positive because the people who had the mitral valve repair had a better peak VO2 with exercise at 1 year after the intervention, and systolic volume was smaller, MR volume was much smaller, and BNP was smaller. So a positive study done carefully, but unfortunately in the cardiac surgery network trial of moderate MR treated by repair, absolutely no difference in outcome, in survival. The repair did not improve the outcome at all in that trial of moderate MR. And we go back, because of that uncertainty, to what we observe in the community. And you see that the surgical treatment of functional MR in that place, which is easy because you have to walk, you can walk to have your cardiac surgery from your home, and it's only 4% over the lifetime of the patient. So we undertreat very severely functional MR due to LV remodeling by surgery. So the surgery has not been able to help us in understanding what's happening to these patients. What about interventional data? So interventional data, you know that it's the clip, and we hope with the clip to approximate the mitral valves so that we would reduce the regurgitation. Everybody knows that. And everybody has had that experience of pre-clip, very high V wave. Post-clip, the V wave disappears, the LA pressure decrease, everybody's happy, and you see the 3D of the clip in place. Now, everybody has seen also the results of the mitral FR trial done in France, where there was absolutely no difference in outcome, and the COAP trial done in the US, North America mostly, with a very strong difference in heart failure. And these results are believable because there is internal consistency. So in mitral FR, the LV volume do not change. In COAPT, not only the volumes change, we're not sure that we can believe them, but also the implantation of LVAD, transplantation is different, and survival is different. So it's not just the heart failure, because you say, okay, how do you label heart failure? You know that these people have a clip, so maybe you're not really honest. But transplant, LVAD, mortality, indisputable endpoints. And so there is incoherence of the clinical trial. We don't know what to do. What about the guidelines? Well, the guidelines started in 2003, American Society of Echo, and you see that at the time, no outcome data had been published apart from the study on ischemic MR. So I was part of the guideline committee, and in the guideline committee, when you're sitting in there, you do what you want. Not always, but most of the time. And so people believed me. I said, oh, the ERO for severe MR is 0.4. I made this table, gave it to Bill Zogby. Bill Zogby accepted it, trusted me, put the table, but there was absolutely no proof of anything at the time. Zero proof, but on trust, they put this, and that was good. But I didn't push it to say, oh, there should be 2 gradings for different forms of MR, because already was a little bit of a struggle. So I didn't want to do it. Retrospectively, I do regret it. And in 2007, the guidelines, the European guidelines mentioned for functional MR, the ERO of 0.2 centimeters square, regurgitant volume of 30 ml. So discordant guidelines that we hope to reconcile. In 2014, it is reconciled in the ACCHA. It's difficult to read, but you see that the threshold for severe MR is 0.2 centimeters square. But then in 2017, the guidelines are reverted to the same threshold for secondary and primary MR at 0.4 centimeters square. So this is completely unprecedented, that wavering of the guidelines, going one way, moving the other side, coming back, and a difference in guidelines between Europeans and US, which is the most striking in all of the guidelines for valvular heart disease. So it is very strange. So here are the guidelines that I participated in 2017. And, you know, there were spirited discussions, especially about functional MR, spirited discussion to the point that, you know, these are all friends, you know, it's all friends. But we took pictures of the spirited discussion, and I'm going to show you one spirited discussion that we had. I don't know. I felt somewhat isolated by the outcome, but my hair is dark, was dark. So that's the discussion. And this is the presentation. And if you look at this sort of graphic of what is supposed to happen for all MR. There are criteria. These criteria in green to say mild, not illogical, but completely unproven. Criteria to say severe, not illogical, but completely unproven. And then you see there is the only thing that reveals the amplitude of the discussion is that box going from yellow to brown, saying, you know, we have some doubts. That's what says, but there was a desire to maintain a unique grading for MR in all forms of MR. To say severe is only above 0.4 centimeters square in all forms of MR. And I could not break this this desire. And I understand part of the desire because you say 1 milliliter is 1 milliliter in ischemic MR, is 1 milliliter in organic MR. There should not be a variation. But we have to distinguish the volume and the impact on the patient. We have known to interpret a number depending on the patient. Creatinine in a small woman and a big muscular guy is not the same. We make an interpretation of the normal value depending on the patient. And that's exactly the same that we want to do, an interpretation. But I'm getting ahead of myself. So functional MR, question remaining. It starts as LV dysfunction. You get the effect, the functional MR, and now it creates a volume overload. And is it affecting the LV dysfunction? And still, in 2020, it's a legitimate question. So what do we do? To try to resolve that, we need new data because we can't go back and interpret data that are flawed, contradictory. We need new data with very large cohorts, comprehensively characterized so that we don't have a doubt about the surrogate variable that is affecting outcome with long-term outcome and with comparison FMR, DMR. And I'm going to show you what we did. So we looked at all the HFrEF, stage B and C, so not stage D, advanced, eliminated the two young patients, all with cancer, and those without quantitation, and we get to 6,381 patients. And you say, 6,000, how do I do it? A good fellow does 400, an exceptional fellow does 400 charts a year. So 6,000 would mean of that outstanding fellow, 15 years? Kind of complicated. An okay fellow does 200. So I would need 25 years of an okay fellow to get there. So how do we do it? How do we do it? And here is the distribution of MR on these patients. And we have, for these large number, to use an electronic acquisition of data. So we had a comprehensive characterization because we had a complete electronic filling of this data. Doppler echo with all the measurements and impressions that are done in routine practice, collected electronically as they were introduced in the database by the physician doing the echo. Clinical, we had the vitals, the symptoms extracted by natural language processing. So you can have that vital information on the symptoms by extracting from the note. It is feasible, it is possible, and because of that, you can treat very large number of data electronically, past medical history, ECG, comorbidity, ADL, meds for clinical notes. Cath surgery performed according to the specific database. Creatinine, many laboratory values, very easy to obtain. And mortality by Accurant, which is a system, proprietary system, that allows you to have very promptly the mortality in the patients in the US exclusively. And so I'm showing this table not for you to read, but for two things. first, the completeness of the information we have on these patients. And second, to show you that for almost all variables, there is a difference between the people without MR, mild, moderate, severe, whichever way you qualify that. There is difference. FMR doesn't come in isolation. Everything is modified with a degree of FMR. So you need to have a powerful description and very large number to be able to make an interpretation. And the first result in that data set is that the distribution of functional MR is completely different from the distribution in organic MR. If you took the ERO above 40 in functional MR, 8% of the patients with MR, 3% of the total series would have that threshold. So using a threshold of 0.4 in functional MR is absolutely nonsensical because you would get almost nobody. Compare in DMR, degenerative MR, 38% of a regurgitant orifice above 0.4. So that this different distribution skewed towards lower ERO shows that you can't use similarly the same scale in both. Now, the second step is the analysis of mortality, and this is a spline curve. And you see, because of the very large sample we have a very narrow 95% confidence interval, and we have a straight line without flattening. The mortality increases within the cohort for each increment of the regurgitant orifice. And what it tells us is that the line of 1 means that you have a mortality equivalent to the average of the cohort. So above that is excess mortality, below that is green, you're good. You have the average mortality of the cohort. And so that crossing of the line of 1 is around 0.1. So what it tells you is that when there is MR with an ERO below 0.1, it has very little consequences, and it has, we're done, or we have a few more, we have a little time, or not? Oh, yeah. All right. So so this is the mild MR. We can define mild MR this way. Here is a multivariate analysis. The strongest is with the ERO as a continuous variable. You see the European grading, the American grading, and this is a proposed extensive grading. And the only message here is that extensive grading wins over the American and the European grading. And here is the survival curve with the no MR up to 0.1, 0.1 to 0.2, 0.2 to 0.3, and above 0.3. And if you look at the American grading, it works. Everything works. The ESC grading, it works. But you see that what works best is an expanded grading, which is more powerful than the American or European grading. And this is a very important spline curve, 2 spline curves of mortality versus expected. So what we express, this is the expected survival in the population for your age. So for any age, you can say, okay, what is the expected survival and observed survival difference? And you can see that that here is DMR. There is a linear increase in mortality with excess mortality above 0.2 and increasing progressively with a regurgitant orifice. This is functional MR. The excess mortality starts at 0.1 over the population, but you see that there is an excess mortality in people who have no MR because you have a low EF. Sure, you're going to have an excess mortality at baseline, but then it increases above 0.1 and it becomes exponential. So the relationship to the expected survival is different with an exponential increase in mortality with any increment of ERO in the FMR versus the DMR, a linear increase in mortality. So I'm going to go fast here because again, here, interaction, we detected no interaction despite the size of the cohort. We detected no interaction. Here, the interaction in more detail, you see the p-values, non-significant for the p-values, whether it's with EF or in diastolic diameter. So FMR outcome, despite the criticism on the method, EROA in routine practice is a strong and independent determinant of survival in FRF. No evidence of modulation of risk by the LV size or function. And that's important because that sort of concept of, oh, proportion, disproportion, they would have you select the patient based on the end diastolic size. And there is absolutely zero rationale to exclude people who have a large ventricle from being treated. So we don't want to do that. And the risk of mortality appears for an ERO of 0.1 and increases exponentially with higher EROA. And so for the grading, we need to have a scale of grading, a different scale from DMR, completely different, skewed towards lower ERO. And the best associated with outcome is an expanded grading scale. And it is time to harmonize FMR grading between ACC-HA and ESC around an expanding scale. We need to harmonize. We need to speak the same language on both sides of the Atlantic. Do I have 2 more minutes? Okay. So we go back to the treatment. How do we understand the treatment? Because the message here is very important. You know, the clip is that issue because the clip has proven in the COAP trial that it can treat functional MR. And we've seen those differences between the two. And how do we understand those differences? The population and the experience of the center were very similar, were a great number. Even the GFR was the same between the two populations. So very similar. The difference, it's not the volume. There is a little bit of difference in LV size between the two studies. The severity of the MR is different, but most importantly is the intervention was different. The achieved implant was higher in COAP, more 2 clips, less complication, less MR at discharge, less MR recurrent at 1 year. And this is a very crucial point, the point of residual MR. Do you leave residual MR after a clip procedure? And you know, in the repair versus replacement in severe MR, the surgical experience, the incredible fact is that there was so much residual MR in the repair arm that it made the benefit of repair disappear. If you repair, whether it is surgical, whether it is for functional MR or organic MR, if you repair and you leave MR at the end of the procedure, the benefit of repair will disappear. And in fact, on the clip, I have this data, not yet published, so we don't want to send slides to anybody, that has been submitted by the COAP trial. And Saib Al-Kar asked me to be co-author on this and to review the data. The residual MR at 1 month is a very strong determinant that, of what happens to the patient, whether you're in the MitraClip arm or the GDMT arm. The residual MR is the critical aspect. There is more residual MR when you don't put a clip, but leaving residual MR is a critical aspect. So to finish with the FMR LV dysfunction, it represents 1/3 of all MR approximately. It is truly an independent determinant of survival and heart failure in FRF. Specific scale of grading, and we need to change and to push that. It is profoundly undertreated, and we have now potentially successful method of MR treatment, but the results has to be perfect to be effective. Well, I think I'm done. Thank you. Sorry for going overboard.
No, I think we would all stay for the rest of the day. That was just wonderful. We'll take some questions, and either from the audience here or from
Maurice, I learned a lot. This is fantastic lecture. I really learned a lot today. But I have a question. Despite the positive findings so far, we still have about 50% of patients that are non-responding trial, recently published observation. If you had the opportunity to design a trial for FMR, what would be your threshold to say you are in this trial for EROs, etc.? And you think that's the answer for trying to limit the percentage of people that are non-responders to therapy?
Well, the non-responders, they pushed a little bit in that publication because non-responder is you die. And, you know, when you have LV dysfunction, you're gonna have a mortality. So it's not non-responder to the device, is you have a condition that may kill you. Does it kill you more with a clip or without the clip? So the non-responder is a little bit pushing to say, okay, 50% are non-responder. If you have 20% EF, we treat the MR, are you gonna live forever? You're gonna still have excess mortality, and that's where the comparison to expected mortality is important. So the issue of each strata of the MR, so if you say, okay, 0.4 and above is very severe, is extremely severe, it's torrential functional MR. These people absolutely need to be treated. 0.3 and above, these people need to be treated, and now I accept the data of COAPT. The question is between the 0.2 to 0.3, which is quite significant MR with an impact on mortality, but not as big as above 0.3. And here you need to have both a very safe intervention and a very effective intervention. So if you do like surgery has a mortality between 5 and 7, 8%. So if you kill 5 to 8% at the outset, you'll never be able to catch up. So you have to be very safe with a mortality of 0.2%, like repair in DMR, to be able to show an advantage. Very safe, and now with a residual MR issue, very effective. So if the high life is very safe and very effective, 0 residual MR, then maybe we'll be able to treat the patient 0.2 to 0.3. Maybe we'll even be able to go 0.1 to 0.2 of regurgitant orifice because these people are already at risk, but the risk is minimal. If you do anything that is untoward, you're going to lose that clinical trial. So it depends on what you're testing. If you're testing something very safe and very effective, 0.2 to 0.3, I would certainly test it. And now, with the results of COAPT, I would treat the 0.3 and above without any compunction by any means. So that's how I would approach the question. Yes.
A couple online questions. The first one comes from Dr. Burke. And the question is, how do we know that atrial FMR is caused by the LA enlargement and not the reverse?
That's a very good question. We don't know much. That's an excellent question. I have data not published yet, sort of finalizing analysis of people who start with atrial fibrillation. And we have a first echo and a second echo. And we see over time development of MR, development of TR. So there is that progression. They start with a big atrium and they develop functional MR, functional TR. So that's my only response, unpublished. So we're not sure.
Great, thank you for that. The other question comes from Ross online, and the question is, Dr. Sarano, how much variability do you think there is for EROA based on the sonographer doing the echo?
Yep.
And the follow-up question is, how long does it take to get an accurate EROA?
Yeah, accurate. What is accurate? It's a human measurement. So for individuals, there will be some variation. We should not conceal that. It's what we're doing is analyzing a group and saying in routine practice, do the number mean something? And you do a routine practice with a measurement by more than 100 sonographer, more than 30 consultants, and they commit and they put a number in the database, and that number is meaningful. Now, is it like a gold standard? There is no gold standard. I don't believe in gold standard, something perfect. Everything that we do is human. There is variability. There is possible mistakes. It's just a general view on the methods saying it can work as a group very well, but you know, you see a number, you have to be a doctor making an interpretation of this number to say, is it logical or is it a mistake? Do I review the images? Do I agree with this? So it does not, having a number on the report does not preclude your work as a doctor to say, this data is reliable or is not reliable for the patient, is clicking with the rest of the patient. So that's the job that we have to do clinically.
Go ahead.
Maurice, that was fantastic as always. So when I think about, you know, some of the things you said about prophylactic therapy of MR, and you're talking about changing thresholds, in your crystal ball view, do you think that we will be clipping or treating patients with EROs of 0.1 or 0.2 even before symptoms in the future to prevent MR begetting MR?
In functional MR, I don't. In functional MR, I don't think so, because these patients are risky. In organic MR, the big question is, you have people in organic MR that are less than severe. The moderate MR really is a big question because we've seen that there is excess mortality in that moderately severe MR. I apologize for the email clicking. And so really, if we find something that is percutaneous, very low risk, a durable repair that we can do at the stage of moderate MR when the mortality has not increased yet, I think that there is a very wide mass of moderately severe MR that will need moderately severe, that will need treatment. And so on the organic MR, I think so. Is it the clip that is going to be the final? Is it an artificial cord? No, nobody knows. Again, safety, efficacy of what we do over time will be, but I think that in the organic MR will go lower. In the functional MR, as people are not treated, if you get us something safe and effective, absolutely, is the moderate MR will be an absolute candidate to be treated.
Mark, so what about surgery? So means the role of surgery in FMR is really dying down. And say if I'm doing a CABG and patient has a moderate ischemic MR, secondary MR, what should we do? Should we aggressively treat it or should we leave it now? Because you said very rightly, if I do a CABG, the mortality is this much. If I do CABG mitral, the mortality increases. I'm talking of, say, 1,000 patients across board. So should we just do CABG? And the Brompton trial showed that, you know, one shouldn't be treating moderate MR in these patients.
Yeah, it's a very difficult question. It depends what kind of surgery you can produce. In the UK study, the study was positive. The randomized trial was positive with a non-clinical endpoint, but was still positive because they paid attention to have no residual MR approximating the papillary muscle. If you can do a repair, the concept is if you want to do a restrictive annuloplasty and that's a therapy like a pill, that doesn't work in all hands. If you're somebody that is going to make a good repair, not only some restriction to the annuloplasty, but doing something on the papillary muscle, maybe it's worth it. Maybe it's worth it, but it's a difficult repair. You know, surgeons were saying, oh, I see the valve, they look normal. The only thing I can do is an annuloplasty. I'm doing the annuloplasty and I'm done, and I do what I can. No, you have to sort of think, okay, it's a type 3B, and I have to prevent the recurrence of MR. 25% in the hands of most surgeons. So what do you do to prevent the recurrence? If you can prevent the recurrence of the MR, then you should go ahead, you do a CABG, you should treat the MR.
I think on that thing, if I may just ask and introduce something here, the recurrence of MR is directly predicated onto the substrate, which is the ventricular scar. And I think, our understanding, I would like to hear your feedback, Maurice. Our understanding about functional MR, secondary MR, has to fundamentally change, because it's not only about a proportionality of volumes, but also how do these volumes interact with the amount of scar. And if you have a lot of MR, but not so much scar, these ventricles probably are asking for help, and we should try to intervene on. And I think that might reconcile, in part at least, the discrepancies between coapt and mitral FR.
It's very possible that the marker of a good and bad ventricle, we all agree that the bad ventricle maybe should not be treated, and maybe it's not a great candidate for treatment or will not have a great benefit. And maybe it's not the volume of the ventricle, because the volume has never told me anything. It's the quality of the muscle. And maybe the quality of the muscle is the fibrosis that you see with CMR. And really the hypothesis that we have to verify is fibrosis a much better marker of what happens to the patient? I'm a firm believer in that. Autopsy studies, when I was in training, people were talking about autopsy studies, and all the autopsy studies of valve disease finished by a lot of fibrosis in the ventricle. That's the ultimate thing that brings them to heart failure. So if you see fibrosis, extensive fibrosis, what is the probability that they will have a benefit from any intervention? Probably very reduced. And I'm completely with you. I think this is a study that begs to be done in patients instead of the rotten volume that we measure by echo. I'm an echo guy. I tell you, it's not reliable in 90% of centers. Having a complete ventricular assessment, including fibrosis by CMR, is, I think, the next step that we should explore.
Just in line with that, is there data out there that show improvement in MR with revascularization alone?
So very little. There is a lot of, there's some growing data that actually patient selection predicated on the amount of scar is actually critically important, but not so much in revascularization. But data from Cleveland Clinic, if you have viability and you revascularize, these patients actually do better, particularly to their complete revascularization. Changes of MR also follow that. If you completely revascularize and you have not significant scar, these ventricles should get better.
And anecdotally, we've had a number of patients who've had PCI and then get excluded from coapt in other trials because the MR has gotten better.
There you go.
So.
But overall, statistically, it's kind of weak. It's kind of weak. That is, the hope that you're going to make the functional MR disappear by revascularization is kind of low. There are cases, but overall, as a group, you say, okay, if I revascularize, do I really cure the patient? Generally not, because you don't get a reverse remodeling that is so strong that you get the MR back to zero. And so you need to do the revascularization, but the hope that it will be corrected without something done to the valve, the annulus or something, is very low.
Right, especially because you have the substrate, the ventricular changes already there, so. Yeah.
Well, we probably should wrap up, but Maurice, thank you so much.
Thank you so much. Thank you.